Okay, hello again. I'm going to explain the wound healing. The first of all, we're gonna have the types of the wound healing and the factors and the dead space and the complication lastly. The first thing, the first intention primary union. So basically wound is suture. Oh my gosh. Oh. Oh, okay, I'm sorry. I don't know what does happen exactly, but oh shit. Oh my god, my iPad nowadays is out of control basically. So, wound is sutured and closed. This is about the first intention primary union. Healing occurs from side to side. Healing occurs rapidly with little inflammation and minimal scarring. Um, Basically, the first intention gotta undergo three phases. The first thing, lag phase or inflammatory or response phase. Lag phase because it takes so many time, it basically the longest. Inflammatory and response phase because the inflammation as a response of the wound itself. So it begins with minutes of the injury and lasts to 5 to 10 days. Inflammation is present, manifested by heat, redness, swelling, pain, and loss of the function. Inflammation is a result of increased blood flow to the area caused by arterial dilatation, bleeding controlled by platelet aggregation. Okay, so once there's bleeding, it's going to be controlled by the platelet aggregation. This is basically the inflammation, the stage of inflammation. Oxygenated blood delivered to the site, and epithelial cells for repair formed. Phagocytosis, basal cells seals wound surface. Fibroblasts begin and not just peak. There's a difference because once it peaks, that indicates we're in the proliferating phase. But once it began, that indicates we're in the inflammatory phase. So fibroblasts began reconstruction of non-epithelial tissue. Okay, the other phase is the proliferation phase. Begins about the fifth day and continues up to 21 days. Okay, fibroblasts multiply, proliferate, and bridge wound edges. Collagen secreted from the fibroblasts. Collagen fibers begin to restore tensile strength of the tissue and capillary network established and lymphatic network reformed. During the proliferation phase, phase 2, the wound healing by the first intention, the wound regains 25 to 30% of its original tensile strength. During the proliferation phase of the wound healing with the first intention, the wound regains 25% to 30% of its original tensile strength. What do I mean by tensile strength? Ability to resist breakdown under the tension. So once you tension that, you tense those edges, there's going to be resistance, and all of the 25 to 30% is established by the proliferation phase. Okay, the remodeling, maturation, or differentiation phase begin at day 21 and last until the wound is completely healed. May take up to 12 months, and tensile strength increased by inner waving of the collagen fibers. Okay, so it increases here by inner waving, will form network. Okay, so this is basically the first intention. The wound healing undergoes three phases. Okay, what about the second intention at the types of the wound healing? The granulation wound is intentionally left open. Healing occurs from the bottom to the up. The risk of infection, if not already present, okay, high risk of infection. Union is weak and scar formation extensive. Granulation tissue containing myofibroblasts forms in the wound. gaps in the tissue fill from the bottom upward, closing the wound by contraction. Epithelial growth is secondary. So basically, the second intention granulation, the concept is by leaving the wound healing by himself without any kind of intervention, because once we leave the wound itself like this, we're gonna have some sort of granulation. The wound start to have granulation, and that will allow the wound to heal, but it's going to be weak, not as so strong as what it should be. Tertiary intention, delayed primary closure. Two granulated surfaces are approximated. Wound is left open to heal by secondary intention for 6 days, and then wound is closed. Okay. Okay, this is the tertiary, the secondary, and the primary or first intention. These are the types of the wound healing, right? Okay, what about the factors of the wound healing? Three main factors influence the wound healing: patient's condition, local or general, like systemic. The local tissue ischemia, right? So once there's tissue ischemia, the wound going to be delayed, not as so fast to heal. Hematoma, seroma, bacterial contamination, foreign body cancer, radiation, all of these going to decrease the speed of the healing, and all of these considered as the local, such radiation, cancer, foreign body, and the bacterial hematoma, seroma, tissue ischemia. What about the general or systemic? Poor nutrition, protein, caloric intake, vitamin C. So basically, the poor nutrition also participates on the wound healing, and is going to delay the wound healing if the patient has some sort of like malnutrition or sort of thing. So protein, caloric intake, vitamin C, all of these participate on the wound healing. Vitamin C, caloric intake, and protein, because the protein makes the fiber, and vitamin C makes the collagen. And the color, okay, it has nothing to do with it, basically. Immunosuppression, steroids, and chemotherapy could also delay the wound healing. Genetic connective tissue disorders such as osteogenesis imperfecta, Ehlers and Danlos syndrome, Marfan syndrome, epidermolysis bullosa, all of these sort of conditions could delay the wound healing, because these are having some sort of problem in the collagen or the fiber formation, so it delays the wound healing. Metabolic disorders such as uremia, diabetes mellitus, these conditions as well delay the wound healing, because the uremia, once the uric acid pulls up inside of our blood or our bodies, we're not gonna have normal platelet function or normal things that participates in the wound healing. Just the same applies for the glucose and the sugar. All of the metabolites going to be altered, and as a sequence, we're gonna have some sort of like just delayed on the wound healing. Smoking as well. All of these are general systemic, poor nutrition, immunosuppression, genetic, metabolic disorder, smoking. All of these are general or systemic. What about the intraoperative tissue handling, which are related to the surgeon itself, length and direction of the incision, dissection technique, sharper plan. Of course, once it is sharp, it helps us to, or it fasten the wound healing. Length of the surgery, hemostasis, which means basically, oh my gosh, okay, hemostasis, the stopping of a flow of the blood. So sometimes, like, I don't know, but the surgeons may give the patient some sort of thing that help the blood to stop from the bleeding, or sort of. So maybe it depends. Okay. Minimal and gentle tissue handling. Okay, so it helps as well in the healing processes. Precise tissue approximation, elimination of dead space, and secure wound closure. All of these intraoperative tissue handling. Application of the principles of asepsis. So we've talked about the patient condition, whether it's local or general, intraoperative tissue handling, and the application of the principles of the asepsis. Data space. So I think like data space, like in nutshell, that means once there is a space not closed, there are going to be accumulation of the bacteria, of the sepsis, and many things. Okay, so the surgeon has to be so aware to close these spaces. Reduce or eliminate a space with the use of the proper suturing techniques, wound drains, to not having some sort of empty spaces. Pressure dressings as well, it helps to minimize those spaces. So the complication, we have dehiscence, herniation, hematoma, fistula, infection, sinus tract, and the main and important complication of the wound, hypertrophic scar and keloid formation, which are all sort of scars. So the hypertrophic scars and keloids, this process does not extend beyond the boundary of the incision or the scar. This is about the hypertrophic scars. This process is exacerbated by tensile lines on the area of surgery. Incision over the knee and elbow have a higher incidence of the hypertrophic reaction. So this process is exacerbated by tensile lines on the area of surgery. Okay, so like in the place of the surgery, we're gonna have hypertrophic scars. Treatment: nearly all hypertrophic scars undergo a degree of spontaneous resolvement. Pressure applied early to a lesion is also of benefit. Intractable lesion can be injected with the triamcinolone, which is corticosteroid. The colloids raised and thickened scarred. This process extends beyond the boundary of the incision, which is a problem, bigger problem actually. Continuous weeks to months post the initial insult. Higher incidence in African Americans. Treatment: pressure applied early may decrease the extent of colloid formation. Injection of triamcinolone. Excision is reserved for intractable colloids and used in conjugation with a POV, like the methods that have been mentioned above. So basically the same method and the same management are going to be applied on both colloid and the hypertrophic scars, which is the important complication of the wound. So we've talked about complication, the data space, the factors, and the types, which is all related to the wound healing. Hopefully you guys have benefited from, and thank you. That's all.